Hello friends, welcome back to channel. So today we will be having a short recall session on medicine questions asked in NEET. First is a patient having bilateral hilar lymphadenopathy with bilateral facial palsy, and he developed blurring of vision in the right eye. So possible diagnosis. The options were tuberculosis and sarcoidosis. So if you see this in sarcoidosis, this is a skating system where this system is used to classify this sarcoidosis based on the severity. First is the class 1 where the patient will have only bilateral hilar lymphadenopathy. Next is where the hilar lymph nodes will be enlarged along with infiltrates radiating from the center, hilum. Next is stage 3 where the infiltrates would have reached the periphery. And is the last stage where lung is replaced by fibrous tissue, fibrosis. So actually this system is very important in taking decisions regarding treatment. If you find that the patient is in stage 1, no treatment is needed because 50% of sarcoidosis recover spontaneously. And if the patient is in stage 2 or 3, treatment is necessary, which is steroids. And stage 4, no role of any steroids as it has reached the end stage. Its only treatment option which can be given is lung transplant. Next is they have also mentioned about this uveoparotid fever, which is seen in sarcoidosis, which is characterized by like patient will be having fever and patient will be having uvea involvement in sarcoid. Sarcoidosis is nothing but granulomas everywhere. Granulomas in the iris, which can form anterior uveitis. This granulomas in the iris, which forms those nodules like Cope nodules, Basaka nodules, the base of the iris, and mutton fat keratic precipitates. All those things will be there. And if it is involves the intermediate and posterior uvea, then there will be chorioretinal lesions, the granulomas. So that might interfere with your vision. That might cause blurring of vision. Or else this KPs can itself obstruct the path of light and cause blurring of vision. And also optic disc granulomas might also form. So all these might be a contributing factor for your blurring of vision asked in the question. Next is, as we know, granulomas can also form in the parotids, causing bilateral parotid gland enlargement. And also this granulomas might compress bilateral facial nerve, causing bilateral facial nerve palsy. There are very few conditions causing bilateral facial nerve palsy simultaneously. And sarcoidosis must be kept in the differentials among if such a question is asked. So everything fits in this sarcoidosis. Next is a patient having hemifacial pain on clenching the tooth. So what is the possible nerve which is involved, structure which is affected? They have marked these structures and they have asked what is the probable structure which can be affected. So if you see this history, what is happening? Unilateral facial pain, which nothing gives a great clue towards trigeminal neuralgia. So why does this happen? Because the superior cerebellar artery in old females, due to atherosclerosis, it becomes hardened and it compresses the trigeminal ganglion. This is the main reason for this trigeminal neuralgia to happen. So what happens really? If you see in this trigeminal nerve, there is components like A alpha, A beta, A delta and C fibers. So A alpha and A beta. A beta, you know that it is responsible for carrying proprioceptive impulses, like whatever movement we do, joint sense, all these are carried by these fibers. What happens is, due to compression of this superior cerebral artery, these fibers are affected, A alpha and A beta. So what happens is, these fibers are becoming hyperexcitable. So this spills off the action potentials into its neighboring neurons whenever they are compressed. So just think, when A beta will be stimulated, you do some movement with your face. This will stimulate the proprioceptive impulses to carry towards the A beta fibers. This action potentials will be slowly spilling into A delta fibers. A delta carries, as we know, sharp pain. So whenever we do some movement or whenever you touch the patient, tactile allodynia, movement allodynia, what happens is this A beta stimulation will fire the A delta also. This will cause sharp lancinating pain, and it lasts less than some very milliseconds. Because of stimulation of only A delta fibers, this sharp lancinating characteristic pain of trigeminal neuralgia happens. Now, how to identify what is the structure which is involved? See, in trigeminal neuralgia, most commonly affected structure will be 5-3, which is mandibular section. Next is 5-2, maxillary. Next will be ophthalmic. In this image, if you see, you can see the mandibular nerve straightly exiting down into the foramen ovale, and two nerves which are passing the lateral wall of the cavernous sinus, which are nothing but maxillary in ophthalmic. So the nerve which is not at all going into the cavernous sinus, which is the 5-3 mandibular section, will be the most commonly involved, and this might be the best. Yeah. Next question. HIV treatment monitoring is done by A. Viral load, B, or P24 antigen assay. So if you see this, as per NACO 2022, the only thing which should be done routinely in this patient of HIV is viral load. Okay, even CD4 count, it's not a routine thing to do. Only viral load, it should be done at the initiation of treatment, and after 6 months you should repeat the viral load. If it is less than 50, this is the target which we need to achieve. Here you can continue the same ART. No need to do anything, you can continue the same ART. And if it is between 50 to 1000, or if the viral load is more than 1000, here you should repeat the test after 3 months and ensure compliance of drugs. No need to change any therapy. After this three months of treatment with complaints, if still the viral load remains more than 1000, then that means it's virological failure. It's an indication to change the regimen itself. Okay, so you can see that only with viral load we are able to take decisions regarding treatment regimen. So obviously answer will be viral load. The serology is given. Hepatitis B SAG is positive, and IgM for anti-HBC is positive, and HCV RNA is negative. So diagnosis is, because in acute, HBsAg will be positive, will be initial to rise, and HBV DNA will be rising along with it. And also after some time, IgM for the core antigen, anti-HBC will rise. Okay, and it will stay even in the positive, even in the window period also. In window period, nothing will be positive except IgM anti-HBC. So they are asking this period, which is nothing but acute hepatitis B. Next, the mechanism of action of botulinum toxin is. Mechanism of action of botulinum toxin is: A, what is it doing with respect to acetylcholine in the synapse? Is it inhibiting the release? Is it inhibiting the receptors, acetylcholine receptor? Okay, so actually what happens? Usually as action potentials in the nerve terminal happens, the acetylcholine which will be loaded in the nerve terminals will be captured by the two proteins called synaptobrevin and syntaxin. They will coordinate this vesicle, and they will transfer this acetylcholine into the synapse, following which acetylcholine acts on the muscle, causing muscle contraction. So in this botulinum toxin, what it does is it inhibits this interaction of synaptobrevin and syntaxin with acetylcholine vesicles. So acetylcholine is not at all released. So this will lead to flaccid paralysis throughout the body. It's a cause of descending paralysis, descending flaccid paralysis. So botulinum toxin mechanism of action is inhibits the release of acetylcholine into the synapse. A patient having lymphoblast in peripheral smear, and he was found to have hyperkalemia, hyperuricemia, and also reduced urine output, and he complains of severe abdominal pain. So here, what to do next? A, hydration, start chemotherapy for this patient, or C, ultrasound whole abdomen, D, I think it's probenazine. So here if you see what is happening, there's nothing but tumor lysis syndrome which is happening. Lymphoblast is having the peripheral smear. So actually tumor lysis syndrome is usually due to rapidly proliferating neoplasms like Burkitt's lymphoma or any lymphomas or leukemias, ALL, all these things. After treating, this tumor cells lies like anything and they release the intracellular contents. Potassium, cells are bags of potassium, phosphates and DNA. So potassium will be released causing hyperkalemia, phosphate will be released causing hyperphosphatemia, and DNA, all this nucleic acid will be released and which will be digested and converted to uric acid. So hyperuricemia. This phosphate, what it does is it binds the ionized calcium and precipitates as calcium phosphate. So ionized calcium will go low and it will cause hypocalcemia. So if you see here, this hyperuricemia, this uric acid will start depositing in the renal tubules and interstitium, causing urate stones. This will precipitate abdominal pain in such patients. So here, what are you going to do? Next step they have asked. So next step, if they ask, always tumor lysis syndrome is an oncological emergency. There is no use in diagnosing with any kind of investigations. Immediate treatment will be hydration with lots and lots of saline, okay, 0.9% NS, and along with allopurinol, and you will be measuring uric acid and potassium sequentially. So if uric acid and potassium decreases, if it comes to some safe range, then you can consider starting chemotherapy again, okay, or else you should always wait for it stabilize. If it is not at all stabilizing, if uric acid is high, serum potassium is high, even after correction, it's better start dialysis immediately, hemodialysis along with RAS puricase, urate oxidase enzymes, to decrease the uric acid levels. This should be started immediately. So obviously here the initial step will be hydration. Next is ECG is given. What is the treatment you are going to give for this patient? So in this ECG, if you see the heart rate, as we told, first is see the large box between two RR intervals. It is obviously less than 3. So it is tachycardia. Next is to see the small boxes. Small boxes in a QRS complex. If it is less than 3, then it is narrow QRS. If it is more than 3, it is wide QRS. Obviously here it is more than 3 small squares QRS complex. So it is wide QRS tachycardia. Next is you are going to see the rhythm. Here the rhythm, if you compare to RR intervals, it's regular. Then there are no P waves at all. So it's nothing but ventricular tachycardia. So here how to manage the patient? First, if the patient is hemodynamically unstable, then you will be giving DC cardioversion. Then continuous CPR for 3 cycles. Then if the patient has stabilized, you can consider amiodarone there, IV amiodarone. Or if the patient is hemodynamically stable, the first drug of choice always will be IV amiodarone. Okay, so answer to this is IV amiodarone. Next, this image was asked, and what is the causative agent? Obviously the answer is warfarin. Warfarin causes the skin necrosis or purple toe syndrome. Next, graph has been given and temperature is marked, body temperature is marked in the y-axis, and so what happens is the points are moving from A to B to C. Temperature is gradually increasing. They are telling happen in this sequence: A, shivering; B, dilation of cutaneous capillaries; or C, sweating; and D, declining chemical thermogenesis. So actually what we need to do here, the heat needs to be increased from A to B to C. So to increase the thermostat in the body, increase the body temperature, what we should do? Body should conserve the heat as much as possible and it should produce lots of heat. Okay, produce heat, what we can do is shivering. In shivering, what happens is during shivering, the lot of muscles are contracted and produces lots of heat. Okay, so shivering is a good mechanism to increase heat. And next mechanisms are cutaneous vasoconstriction, so that blood flow to the skin is reduced, no sweating happens, okay, so that this heat is diverted to visceral organs. Next is thermogenesis should be stimulated, not inhibited. So obviously the answer should be shivering. Next, an ABG, simply they have asked pH is low and PCO2 is high, bicarb is high. What is the diagnosis? It's nothing but pH is low, so acidosis, and PCO2 is high, carbonic acid is high, so respiratory acidosis. Next, a patient of acute rheumatic fever, and patient doesn't have any evidence of any carditis, no carditis. So what is the secondary prophylaxis you can give for this patient? A, 5 years since the last attack or up to 18 years of age, or 10 years since the last attack or till 25 years of age, lifelong. So here what they are asking, secondary prophylaxis. So the list is when the patient have acute rheumatic fever with no carditis, then you should just give for 5 years since the last attack or 18 years of age, whichever is longer. And if it is having a mild carditis or healed carditis, there you should be giving for 10 years since the last attack or 25 years, whichever is longer. Next is, if the patient has severe carditis, here you will be giving 40 years since the last attack or lifelong, whichever is longer. And the last thing, valve surgery. After valve surgery also, it's possible in the remaining valves. So lifelong prophylaxis should be given even after valve replacement. Okay. So a patient with dental caries is going to undergo tooth extraction. In which of the following conditions prophylaxis for infective endocarditis is not recommended? A, uncorrected cyanotic heart disease, B, ASD, C, mechanical valve, D is previous history of infective endocarditis. So when do you give prophylaxis for infective endocarditis? Only when there is a high risk patient with a high risk procedure. Only when both are there, then you should consider prophylaxis. Okay, high risk patient means some 4 categories you should be remembering. First is the patient a history of previous infective endocarditis. If one more attack comes, it will be very severe and it might lead to complications. Next is prosthetic valves. They need prophylaxis. Next is congenital heart disease. If you see, if it is cyanotic, then if it is uncorrected or partially corrected, they need prophylaxis. Okay, and usually acyanotic heart disease doesn't need prophylaxis. Only even if it is in ASD, after patch closure, during 6 months they will be needing prophylaxis. But after that, they won't be needing prophylaxis. Any history of cardiac transplant, all these things are the high risk patients. Now we will see high risk procedures. High risk procedures means anything, any dental work involving manipulation of the gingival tissue or periapical portion of the tooth, okay, or any perforation of oral mucosa. All are high risk procedures. So what to give in this? Ampicillin 2 grams, ampicillin 2 grams, or azithromycin, clarithromycin 500 mg, or you can give clindamycin 600 mg. Everything half an hour before the procedure, only a stat dose. The most fitting option will be ASD. Next, a patient with altered consciousness, irregular pulse, and pulse deficit of more than 20, and what can be found in his JVP? So irregular pulse with pulse deficit more than 20, more than 10 means it is nothing but atrial fibrillation. In atrial fibrillation, all multiple parts of the atrium trying to contract, but effective contraction is not happening. If effective atrial systole is not happening, the A wave, atrial kick doesn't happen. So A waves will be absent in JVP. Which of the following is the drug of choice for treatment of acute migraine? They are given features of phonophobia, photophobia, and autonomic features. So A, propranolol, sumatriptan, flunarizine, topiramate. Obviously answer will be sumatriptan. See, migraine acute attacks, the treatment of choice drugs will be, first you will be giving NSAIDs, next you will be giving triptans. Triptans mechanism of action is they will stimulate 5-HT1B1D, which has vasoconstrictive action. It can cause coronary vasospasms, cerebral vasospasms. So only these triptans are contraindicated in patients having CAD as well as CVA patients. And also it stimulates 5-HT1D, which inhibits the release of the CGRP, and the neuroinflammation is reduced. Okay, so this is the main action. So what we did recently is we have introduced the recent drug called Ditens, lasmiditan, which has only this property of 5-HT1D agonism. It doesn't have this 5-HT1D agonism. So it is safe even in CAD CVA patients, lasmiditan. So options obviously sumatriptan will be the answer. And other three, propranolol, topiramate and flunarizine, all are given for only for prophylaxis of migraine, not for treatment. Patient presents with fatigability, ECG shows depressed ST, short T wave and U wave is present. What is the diagnosis? Hypernatremia, hyponatremia, hyperkalemia, hypokalemia. So what is happening here? Patient is having fatigability along with these changes. So usually if you see this action potential, this is the cardiac action potential. In the phase 2, 3 and 4, what is happening? Potassium is going out of the cell. K plus efflux is happening. So if you see, according to this, I have drawn the ECG curve. So in this curve, if you see the phase 4 part where the potassium is effluxing, only potassium is effluxing out in the last phase, which contributes to the repolarization phase and which contributes to the T wave. So what happens in hypokalemia is, outside the cell, potassium is very low. So from the cell, myocardial cell, potassium from inside the cell, it will be pouring out continuously. It will be going out continuously since outside the potassium is very low. So this K plus efflux will be prolonged to that extent that this T wave will be split into two. A small initial T wave and followed by a large U wave. Okay, so this is called U wave. So if you find this short T wave and a large U wave, it is nothing but hypokalemia, and patient has fatigability because of this hypokalemia and muscle weakness. 68-year-old diabetic patient with history of COVID infection 4 months back presents with loosening of teeth. What is appropriate action? HbA1c, serum ferritin, nasal swab for mucor. They are just telling history of post-COVID diabetic patient hai, plus loosening of tooth because of sinus involvement, maxillary sinus involvement, nothing but mucormycosis. So you will be taking nasal swab for mucor. The marker of B2, vitamin B2 status in RBC is nothing but glutathione peroxidase. Transketolase is for vitamin B1. Okay. Next, a known case of diabetes, type 1 diabetes, random blood glucose 588, urine for ketones was positive, and patient was having altered sensorium. So in this patient, what is the treatment? IV fluids alone or IV fluids with regular insulin infusion, IV fluids with long-acting insulin. Nothing but, first for diabetic, this is nothing but diabetic ketoacidosis, which is given in the question. In DKA, first treatment should be to wash off the ketones. You will be giving lots of fluids along with insulin infusion, which is nothing but the regular insulin which is used. And 3 questions were asked for toxicity and drug of choice. One is paracetamol toxicity, drug of choice is N-acetylcysteine. And digoxin toxicity, drug of choice digibind. And one more question, opium toxicity with patient having altered consciousness, comatose state and respiratory distress. Obviously answer will be IV naloxone. Naltrexone is for maintenance, chronic therapy, long acting. Okay, it will be used for maintenance to prevent withdrawal. Acute settings, drug of choice will be IV naloxone. Then this question, a woman on antidepressants and the ECG is having wide QRS complexes and patient is in hypotension and altered sensorium. So for this patient, what is the drug of choice? A. Physostigmine, B. DC cardioversion, C. IV soda bicarb, and long. So nothing but it is TCA toxicity, tricyclic antidepressants. TCA inhibits lots of receptors. One is peripheral alpha-1 adrenergic receptor, which is responsible for vasoconstriction. So this won't be happening at all due to toxicity, causing vasodilation, and this results in refractory hypotension. Next is inhibition of this muscarinic receptor. So if this muscarinic receptor is inhibited in the heart, it will cause tachycardia. And this cholinergic receptors, if it is inhibited in the brain, that will lead to delirium, altered sensorium, seizures, all these are possible. And also in heart, what happens is slowly the patient will be developing features of widening of QRS, and slowly patient will develop VT or VFib, ventricular fibrillation. Pupils, if you see, since it is anticholinergic, pupils will be dilated. Anticholinergic, so urinary retention might also be seen, and hyperthermia might also be seen. So treatment of choice is nothing but soda bicarb. To prevent this cardiac toxicity, we are giving this soda bicarb for this patient. Next, a person taking ATT for a long time develops paresthesia or burning pain over bilateral lower limb. What is it due to deficiency of dash vitamin? B6, B12, B3. What is the vitamin? Nothing but B6. Due to isoniazid component in ATT, this can cause B6 deficiency, due to which patient can develop peripheral neuropathy, that painful peripheral neuropathy. So to prevent this complication only, we supplement ATT with pyridoxine, which is 20 to 40 mg OD. But if the patient has developed peripheral neuropathy, then we will give pyridoxine of 100 mg OD. A child having HLA-DQ2 positivity and on dural biopsy shows script hyperplasia villus atrophy, and in this patient, what diet you are going to prescribe? Lactose free diet or gluten free diet? So HLA-DQ2, nothing but it indicates celiac disease. Along with this, biopsy findings also indicates celiac disease. So in this patient, you will be obviously prescribing gluten free diet. How to diagnose MDR TB? Resistance to isoniazid and rifampicin, resistance to H plus R plus kanamycin, resistance to H plus R plus leoflox. So let's see all the resistance pattern in tuberculosis. First is, if it is first line drugs, HRZD. If it is resistant to any one of the first line drug, then we call it as mono drug resistant tuberculosis. If it is resistant to H plus Z or E without involving R, then it is called polydrug resistant tuberculosis. If H plus R with or without any first line drug resistance is there, then we call it as MDR TB. Okay. If this combination associated with some fluoroquinolone resistance, then we call it as pre-XDR TB. And if this combo along with bedaquiline or linezolid or moxifloxacin resistance is there, then that is the XDR TB. Okay. Yes. So the answer to this question will be MDR tox is nothing but H plus R resistance. That's it. Thanks for watching. We'll be coming with follow-up video soon. Thank you.